Okay, we've been sent an interesting case today. It's the first one that's been submitted like this, and it's a good opportunity to talk about, excuse me, a few different options. This particular patient was submitted with the following notes. The history is patient had existing partial and then needed tooth number 6 taken out. It was extracted. What the notes say was traumatically. I don't know if they meant to say atraumatically, and it was grafted at that time, approximately 4 months ago. So based on the grafting comment, I'll assume that it was maybe traumatically taken out, maybe some buccal bone was lost or something. The patient is now interested in a few implants, 2 implants, to help retain her partial. I would like to place the implants in site number 5 and then either site number 8 or 9. Let me know your thoughts. So this is a great option. So when we start looking at overdentures or overpartials, we start having to evaluate the use of either locator abutments directly to the implant or the use of a bar. The bar brings in, especially on a case like this, lots of space issues and different things like that. So the first very positive things that were done here are a couple of different things. One, this patient was scanned with a bite plate, as you can see by here, by the fiduciary markers. And then number two, we also have a full arch CEREC scan here. Looks like it was scanned with the partial in the mouth, which is fantastic to help us plan the implants. But based on the fact that the CEREC was able to integrate, and it looks quite accurate actually, we could technically have this fabricated as an OptiGuide. So that's an option. But the beauty of having done it the other way is that now, in the case that we weren't able to do the CEREC scan integration, that we could still have a guide fabricated. So if we take a closer look at this, I can see exactly why we did a classic guide scan. If you take a look here, in theory, none of these teeth are reliable. Doesn't mean it doesn't work, but reliable for CEREC integration. But as you can see here, we were able to, this dentist was able to integrate the data, and as we can look through here, we can see that it integrated quite accurately actually right there. And also I want to go ahead and point out that a fake restoration, one of the necessities to be able to integrate data was drawn here on tooth number 7. Basically a non-tooth was drawn there just to be able to get the data integrated. So that's why that's disappeared. So now we can move forward to our planning, and let's go for this. So let's briefly take a moment to talk about some of the pitfalls that we have to avoid with overdentures and overpartials. What I would like to do to demonstrate this is I'm going to go to this 3D screen here and clip along active slice, and what this will do here by clicking the axial is it will get rid of the bottom jaw for me here, and now I can turn around and take a look here and look at this. So one of the issues, and my preference is a locator abutment, um, uh, just my personal preference, but one of the issues we have with locator abutments is they use O-rings and housings to snap onto the abutment, onto the locator itself. So when we have deviations of parallelism, then we have the risk of these O-rings not fitting, creating a path of draw issue, or the O-rings not working or lasting as long as we'd like them to be. So one of the things I like to look at when planning overdentures over partials is the ability to keep these pretty parallel to each other. I know they have extended range, allow 20, 30 degrees of divergence, but those just aren't as good. But to be able to keep something relatively parallel, maybe 5 to 10 degrees maximum of divergence. So the first thing I'm going to look at here is we are probably pretty close based on this right here. Again, it's very hard in the anterior compared to the posterior to create that angle, to maintain that parallelism. But I think as we go through this, we may be able to achieve that quite nicely. The other thing that I keep in mind is, again, space issue. So with this partial, we're going to want a metal framework. I encourage you to always do a metal framework with any type of overdenture. One, because the force is going to be greater on that because the patient's going to have something to retain it. Two, because the acrylic will be thinner. And then three, the housing really takes up quite a bit of space here. So one of the things that I like to do is try not to put the locator towards the buccal of these teeth, because this housing is going to be bigger than the locator, which is bigger than the implant, and deeper. So we take the risk of creating a very thin tooth that may pop off right here. So what I like to do is plan my locators a little bit more lingual to where the denture tooth is already hollowed out to allow the acrylic to attach to it. So one of the things we'll be doing on this plan is moving that a little bit lingual. And the same here in the anterior as well. We just don't want to risk aesthetic issues. So let's go ahead and take a look at tooth number 5, or implant site number 5. And my first question here is going to be this buccal defect. I don't know if that is simply left over from the extraction, needs time to calcify in to the bone to remodel in, but at the 4-month mark that should be there. So I'm very concerned that that implant may not be totally in bone. That doesn't mean that it can't be placed and then grafted. But at this stage, we want to try to simplify things. So one of the things I'm going to look at, and in looking at it from this angle, is this implant is angled out the mesial here. So one of the things I may want to do is just move that. And as I'm looking here in the tangential view, I'm also going to look in the 3D view and get that to where it comes out the part of the tooth there. Now we can see that one, we are a little bit more parallel to that tooth going down the long axis. And that's a more ideal position. That still does not help buckle situation here. So the next option is to go maybe a little bit more distal, and still is starting to get a little bit better, but I would bet as we go in the 360 view, we're going to start seeing the defect is still there. So we may need to graft this site right here. Now, my personal belief is this is a great site to graft at the time of surgery. The bigger issue is going to be the temporary partial and how it's going to affect the healing. That area of the partial maybe need to relieve significantly to avoid any type of pressure on the graft site. And also, if we go back to number 5 here and where I would like this implant to be placed, I'm just going to grab the head of the implant, the base of the implant here, and I'm just going to tilt it, tilt it, tilt it until I'm just coming out the lingual cusp of tooth number 5 there on the partial. So now I'm starting to be a little bit more comfortable with my placement in the sense of location for the locator abutment, just like so. So I prefer this location for my locator abutment here. And just, there we go. So again, be prepared to graft this site if this is the site that we choose to use. Just to kind of see, let's put another implant in. Let's do a 4x13 here, and let's see if there's space elsewhere to be able to do this. And there's a lot of bone right here. But again, the issue now is going to be angulation on this particular implant. As you can see, that's a disaster waiting to happen right there. So I would certainly avoid an implant in this site. Yeah, I would avoid an implant in that site. So now let's go to an anterior implant and take a peek. And here we have good bone, certainly. And let's take a look at this implant. And here we also have good bones. The one thing I would say, since we're using a narrow diameter implant here, let's go ahead and go to a longer implant. And I did forget to check that here on this posterior implant. We have it planned for 3.5. I do believe a 4.3 will work quite nicely here. And in that situation, I would be quite comfortable with 11.5mm implant. But if we wanted, we could certainly also place a 13mm implant here as well. So again, for longevity, for future considerations, if possible, let's put a larger implant in the site. So here we see that this space is quite tight in site number 9, and that would probably not be my preference. Again, the housing becomes bigger, becomes thinner right here on that area. So my preference may be in this particular case to go to site number 8. And as we can see here, we have some room to maybe parallel that and bring it over to the mesial a little bit. And now we're starting to look like we have plenty of space there. So, again, I think we need to dial it in a little bit right here on the buccal. That wall is a little bit thin. So we can go here like so, and boom. Now I think we're talking. And again, I would go to a 13 millimeter implant. I would take a look, does a 4.3 fit, and not bad. It's a little thin right here on the buckle, and I really don't want to mess with that buckle plate. So I'll probably go to a 3.5 there as well, but buy a 13 implant. So let's go ahead and take number 9 and delete it. And let's put it in site number 8. And I think right here, we now have a pretty good plan. We have the ability here. Again, I'm concerned about my divergence. If you take a closer look here at that angulation, that's a pretty decent angle right there. So what I would like to do is tilt this back, and now we're looking a little bit better, and I think that that will actually work pretty nicely. If we also take a look back here at number 5 from this angle, you can see it's still tilted to the mesial a little bit. So we may want to consider just tilting that a little bit more. I think that'll work quite nicely. And there we go here. And as we take a closer look, I think we have a great plan. So hopefully this has been helpful, and it totally makes sense. And uh, I appreciate it and look forward to the final results. Thank you for sending the case in.